Good morning, welcome back and thanks for staying with us. You're watching Daybreak. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. You are joined this morning in studio by the chairperson of the Rural Urban Hospitals Association of Kenya, Dr. Brian Lishenga. Good morning, Dr.
Morning, Abdi.
Much appreciated and thanks for your time.
Thank you so much.
And also we are joined by Dr. Dennis Miskela, the Deputy Secretary General, the Kenya Medical Practitioners and Dentists Union. Good morning, Dr.
Good morning.
Much appreciated.
Thank you for having me.
From our studios in Kisumu County, we are joined by Dr. James Nyekal, the chairperson of the National Assembly's Health Committee, as well as the representative of the great people of Seme constituency. Good morning, Dr.
Good morning, Abdi.
And I begin with you, Dr. Nyekal. You are on a fact-finding mission to inspect other hospital facilities after finishing up with that exercise in Nairobi County following the claims of fraud that have come up regarding payments that have been made to healthcare facilities across the country. What has your first exercise managed to establish in Nairobi County?
Normally, I don't like to talk a lot about what is in process. But so far, what we found is that at least the hospital we visited, one of them was claimed, but there's a hospital with two facilities. So one facility is Nairobi, the other facility is in I think, Wajir. But actually, they have the same name, but they are actually under different management. So that means we'll have to go to the other one as well, because the one in Nairobi is managed by a totally different group of people and doesn't seem to be the one that is actually affected by this issue. So the one in Wajir is also under totally different management. So our problem is that with the same name, different management, would there be confusion? Now we are looking at the facts into that. The other thing we found, we're not just looking at the money that has been properly paid, but also we are looking at what debts are owed to these facilities. So we actually find that, again, these particular ones we looked at, there are actually debts that they are owed and their payments that they have received, and what is owed is much bigger than what they have received. The other problem we are finding is the payment is in bulk. So if you ask them, what have you been paid for and what is pending, it's difficult for them to split out. So that's the information we'll have to get from the SHA itself. Now, so there's a problem of the process of payment, so that you bill and you get paid in bulk, and they don't seem to have the details of how the payment is made. So I think that's what I can say for now. The other thing we've realized, there's a big difference between, we visited a government facility and a private facility. And what we find is that the level of knowledge of the working system of SHA is very different in public facilities and in private facilities. It does appear that, at least from the two we saw, that the private facilities know quite a bit, in fair amount, what the system is and what the problems are and how claims should be made and issues, how they need to follow up. Though it came out that there is no proper system, so that if you have a problem with SHA as a hospital, who do you talk to? The system as now does not give a lot of communication between the facilities and the SHA system itself. When I say system, I don't mean machines, I mean including people, because the nearby offices that belong to NHIF no longer operate, and they have not been replaced by similar. It is said that the digital system will take care of that, but we found that that is not working for well. So facilities have a problem solving problems, even when they want authorization for treatment. So we are out looking at a broader issue. The issue of the fraud is one. The issue of the debts owed by private facilities is one. The issue of how are the systems working That is creating a lot of problems.
Okay.
The other thing we have found is that in public hospital, where they are level 5, and we look at smaller ones, the people in outpatient have a problem because the outpatient is not covered under the premium that is paid into SHA, which is actually SHIF. They should be covered under the primary health care. But that system is not already in place, so they're not getting. They're supposed to be referred from nearby level 2, level 3, but that's not happening. So in public hospitals, now they are actually paying. They told us they are waiving, but my suspicion is that those people are being sent away without getting treatment, or they are paying when they are in outpatient. So we are in a fact-finding mission. Will be in Homa Bay today to look at one of the hospitals that was mentioned about the fraudulent payment. We'll also look at a private hospital and also a government hospital, so that by the time we finish, we have more information. Tomorrow we shall be in Western, and we have a team who are already in Central. And, so that by the end of this month, we may have more information to say on what about these frauds, what about the systems, what about the services that are being offered to the people. Then we'll definitely sit down with the minister and say what is the best way forward to make this system work for the people of Kenya. Right now, there are a lot of hitches.
Thank you. We'll still be engaging you, Daktari, as the chairperson of the Health Committee of the National Assembly, also joined in studio by Brown Ashira Olale. Thanks for your time, Brown.
Thank you so much, Abdi. Asante sana.
To you, Dr. Brian Lishenga, Dr. Nyikal points out, so far from their observation, fraud, debt management, and system or technical problems. It seems that these are compounding problems for our healthcare system.
So Abdi, this question is very interesting because it has different facets. But before I comment on the issue of the problem of fraud, there is something that is on my mind as a representative of private hospitals. If I had the chance to address the head of state and the cabinet secretary, what I would say, in particular to the head of state, is, his personal story. His personal story is quite inspiring. He mentions that the story of his life is impossible, ideally for most people, because he started out as a poor person. Yeah. He was not a member of a dynasty. He was not blessed with a lot of resources. He was a chicken seller. Yeah. And today he's president of Kenya. He says his story is the story of determination and resilience. I want to draw a parallel to what is happening in the health sector. The people who run private hospitals and private facilities, most of them are not dynasties. They are not blessed with the great backgrounds. They are people, they are what we would call hustlers. They have nothing. They have built, some of them have built these healthcare facilities over many years. Mm-hmm. Now, I wanted to pose a question to His Excellency the President, which is very key to our discussion this morning. So suppose when he was coming up as, a seller of chicken, somebody had labeled him a chicken thief. Would his story have been possible? Say if when he was coming up and he had given somebody eggs on credit, and when he went to collect his money, he said the eggs are stolen. Would he have been possible? Would his story be possible? What we are seeing today in the country, Ayub, is a state where everybody in the private sector has been condemned without being heard. It's the fraud problem that we are talking about. I looked at the minister's statement, Honorable Duale, and I was disappointed. To be frank, I was disappointed, and it's unfortunate that it seems to have sent Dr. Nyikal on what I would call a wild goose chase. He will find something, but he's not going to find the magnitude of the problem that the cabinet secretary is referring to. Let me give you an example. CS wakes up one morning and says there is 10.6 billion fraudulent claims. Shocking, totally shocking for the entire country. Then we are expecting him to give us an incredible expose of 10.6 billion fraud. Then what does he do yesterday, the day before yesterday? He presents a list of 1,988 facilities. When you break down, so the numbers look massive, like 1,000 facilities are involved in fraud. But when you break down the numbers, what do you get? You get 24 facilities whose cases they have finished investigation and they are recommending for further action. Then you have 61 facilities whose are still undergoing investigation. And then you have 105 facilities who are had SHA contracts but came PDC. The numbers are not adding up. 24 facilities is very few, and we have looked at the list of the 24. Do those 24 facilities, Ayub, account for 10.6 billion worth of fraud? I will tell you what's happening.
So the point is,
there
claims that were made, which was not supposed to have been the case?
Simple mathematics, Ayub. Even if you were to say 24 healthcare facilities are responsible for 10.6 billion, you are saying each facility has stolen from Kenyans 446 million Kenya shillings. Can the Cabinet Secretary, if he is serious and if this is not a joke, can he publish against each of the 24 facilities how much money have they been paid? Okay, does that money add up to 10.6 billion? I will tell you what's happening. SHA is unsustainable. There is no formula that they have to sustain SHA. SHA is generating every month, Ayub, every single month, the claims that are coming out of Kenyans visiting hospital are worth 9.7 billion Kenya shillings. These are Kenyans visiting. 500,000 Kenyans, thereabout, visit hospitals every month. They generate 9.7 billion. SHA is collecting, at best it is collecting 6 billion shillings a month. They are running at 3.7, yes, SHA is running at 3.7 billion, let's say roughly 4 billion shillings deficit monthly. Now, if you are sitting at SHA and you are looking at your numbers and you are running 4 billion in deficit, you are on course to 48 billion shilling deficit at the end of the year. The president is going around the country saying, go to hospital, it's free, it's free. So people are flooding hospitals. Of course, you tell them it's free. They flood hospitals. These people end up in admissions, they end up with procedures. Now your dashboard looks crazy. You have 48 billion shillings in deficit, and we showed in our statement the other day, numbers which have not been denied, that SHA is in arrears of 43 billion Kenya shillings within 10 months. What do? They have to declare a big chunk of these claims as illegitimate. Whether they are or not, if you ask me, Ayub, the biggest amount of money has been paid to referral hospitals. Why can't, the biggest amount is been paid, 27 billion shillings has been paid out of the 53 billion that they have paid so far. 27 billion shillings has been paid to level 5 and the level 6 hospitals. If you ask me, isn't that where we should be looking for fraud? If 99 hospitals only, because there are only 99 in Kenya, have received half the money, are you telling me that you are going to look at small dispensaries all over Kenya from... The point I'm trying to say is that they are fighting sustainability. And then they have decided everything is corruption.
Okay. So, Brown, I'll come to you and Dr. Miskela. Allow me to get back to Dr. Nyikal as well. Daktari, then what happens? Because funding for healthcare is critical, and the Private Hospitals Association's representative here argues that the authority is already running a 3.7 billion deficit. What then happens from funding perspectives, given that you chair the Health Committee of the National Assembly, which is the holder of the pass in making allocations?
The issue of actually SHA is actually a financing mechanism. And you see what is happening in the country is that people are focusing on the money. People are not focusing on the other things that will make the health system work. And let me tell Dr. Lushenga, I've not been sent by anybody. This is the decision of the committee that before we get in and start talking, we must find out what is happening. Now, the money that goes into SHA, there is the money that is generated through the payment of premiums. But there is some money that is actually coming from the government. and you have heard the president say that 23 billion has been put in. Actually, it is actually 21 billion, which is 8 billion for emergency care, and 13 billion, which is for primary care. What is happening is, as it is now, these three funds, what is being raised from Social Health Insurance Fund and what is coming from the government, there has been no, what is apparent to us even now, there is no harmonization so that all these monies work together. So what we'll have to look at is how much money is coming into SHA. Now, the claims that are coming from the facilities, how much are they earned? Are these claims all related to the money for Social Health Insurance Fund, which is premium? Remember, there's another 8 billion that has come in, which is emergency care. And that money, as far as I could find yesterday and where we are going, it's actually not in the system. People are not being paid. Hospitals are not getting paid through that financing. Now, outpatient, which is actually the biggest, there is that by 13 billion. We are so far, and we are going to work out, we have not seen how that money is reaching the facilities, and more so how it is going to reach the private sector. Now, as much as we may not be generating a lot of money, even the little we have generated is actually the harmonization of its work. Look at the claim system. Dr. Lishenga today is talking broadly, he's not talking in details, but we have not gone into the details. How does the money actually move? There's a problem there. That is so that it will be very difficult to have the services run if they have level 4, like the private sector level 4. Now they have inpatient, which is to be paid by Social Health Insurance Fund itself. They have outpatient, and in all these hospitals, outpatient is a very major fund. Now, the outpatient is supposed to be free. That is what the president is talking about. But the money that has been put, as far as I can see now, has not come out. During NHIF, it was being paid as capitation. Right now, they haven't worked a system of actually this 13 billion getting to the hospitals. So what I'll advise on both sides, the private sector, the public sector, health sector is the same. This private and public is just because of the way it is funded. But really, we should look at the whole sector should say, what is coming now? Okay. How are we using it? Now, the system of claim and payment is also a huge issue. I won't jump and say there is not sufficient money. I would say what you have, how are you using it? The claim system is where this issue of fraud is coming. What we looked at, why is sometimes some claims rejected? And then the hospitals are telling us, even when it is rejected, we are not even getting good reasons. Now they're starting to put reasons why it's rejected. There is no way of how you claim back, how you go complain and say that this has not been paid, it has been rejected, why has it been rejected, who do I talk to? So as long as we avoid these details of using what is available, then even if we get more money, I think we'll have a problem. Thank you. None of us so far have talked about how do we improve the money that comes in. So how do we improve the money that comes in? That we have not talked about. Okay. We'll get back to you. Okay, Dr. I'll get back to you. Is to look to. Yes, I'll get back to you, Dr. Allow me to also get the comments from the Kenya Medical Practitioners and Dentist Union, Dr. Meskela. Thanks again for your time. Ideally, there is a glaring problem that all stakeholders cannot run away from, is it?
Yeah, thank you very much. And the viewers and Kenyans who have followed up the position of KMPDU on this matter, SHA, is that from the word go, we said that SHA, as was conceived, had some problems. And sometimes very disappointing when I see the politicians and the MPs tweeting like all of us or doing press conferences like all of us. Because they are the people who made the law. KMPDU gave a 25-page document of why SHA, as was conceived, was going to be problematic. And I remember the former CS boasting how not even a comma was changed. Yeah? And so right now, whatever is happening is that the wind that is exposing the chicken's tail is blowing from behind. What do I mean by that? That there are certain principles of social insurance that were ignored when SHA was being conceived. One of them is that, did you ever consider issue around the adverse selection? When you tell people that you can fall sick, then register and go get treated. It's like buying a car, you don't insure it, then when you knock it, then you are told you can now pay for the insurance. Even if you made to pay 40,000 and the repairs is 200,000, going to be a loss. The same loss that Lishenga talked about, that the claims, the loss ratio is too high. Number two is about the problem of the Kenyan people, called the moral hazard, that since you know you have an insurance cover, you will go to hospital for anything and everything. And at the same time, the healthcare provider knows that you have a cover. Then if they just removed a toenail, they'll give you a very big surgical name and claim higher. The problem that started the SHA is that us as Kenyans ourselves, we are very, very corrupt people. We have not protected the SHA enough. And my brother and my colleague, Dr. Lishenga, will try to defend the whole fraud thing. The whole fraud is a reality. And in fact, it is worse than in NHIF days. Why do I say so? Because in NHIF days, only private hospitals were desperately looking for how to run their costs. These guys have to pay employees, buy drugs, and all these things. But right now, one of the 4 laws that were passed last year was a facility improvement fund, where money is collected at a facility is wired back to the facility. It's a good thing. But the challenge with it is that now even public hospitals are now engaging the fraud because they want the money to come to them. I know of a doctor, colleague who told me that he has a private sector background and he has learned to ensure that any given time the wards are full to ensure that they get maximal SHA reimbursements and claims. So SHA is there enough for our needs, but can never be there enough for our greeds. And why do we have to say this? The whole idea when they were forming SHA, some people went and borrowed the Thailand model, which is perfect. But what they forgot that 80% of Thais go to public hospitals, where in the public hospitals, the workers are being paid by the exchequer. So these hospitals don't have to worry so much about paying the salaries. Vis-a-vis somebody who opens a clinic for business. Yeah. Right now, almost 60% of Kenyans go to private hospitals. These guys are in business. So when you don't pay them and delay their claims, our members in the union go without salaries. They can't pay rent. People are getting fired. Hospitals are getting closed because nobody opens a hospital because they love Kenyans. They're in business. And when you're in business, you also have to add certain charges. The drug that would cost 100 shillings, they'll put maybe 500 shillings to put markup. And also the uncertainty and the unpredictability of the payment makes you want to have some buffer. And finally, some of these hospitals, also because of that unpredictability, once you insist on cash payment, they'll tell you, the system is down. This is not working. The other day, I had a relative go to JTRH in Kisumu, and go to the CT scan room. It's like a marketplace. Everybody is sitting waiting for the system to open up and work and serve them. How come this system works when you're supposed to be paying for the premium, but when it comes for it to pay for you, all of a sudden this system is crashing? Yeah? And one thing I want to tell the government, that as long as the numbers of patients in Kenya, that for you to get proper treatment, you have to go to a private facility, SHA will never be sustainable. We have been told about the numbers, and the numbers are just a tip of the iceberg. We must find ways of driving the numbers back to public hospitals, where at least you don't have to worry about salaries of employees, where chemist can give you drugs and wait for 3 months before you pay for those drugs. But expecting the private sector people, and people normally ask as I finish, that is SHA working or not? And that's a question that I keep on saying, that somebody who says that SHA is working is not wrong. Somebody who says that SHA is not working, they're both not wrong. Why? Because if you go to a hospital in outpatient and you pay cash when you have been told that it is free, to you it's not working. When you go and you're admitted and SHA pays your inpatient admission and it's served, to you it's working. So we have to ask ourselves that this 80% of Kenyans who go to outpatient and don't get the cover, what can we do to mitigate their issues? Because so far, their voices are louder than the 20% who are being admitted and are being served.
Okay. I'll come to you, Brown, because we need
can
to...
Can I take something?
Yes, Dr. Nikali.
Can I come in, Abdi Kadir?
Yes, please.
Abdi Kadir, can I come in?
Yes, please. Yeah, go ahead.
What Dr. Skella said is actually real, that there are 3 funds, and one is working on inpatient. So those who go for inpatient and are paid the premium get the service. Now, outpatient and emergency services are the ones that have not actually been put in place. So the people are going, but they can't get. So what I'm saying, the issue of the system, as we put it before, during the law, it's true. We raised this issue. We are here with it. Either we go back, or what we actually do is, how can it work? The 3 funds, how do we harmonize them so that some work goes on? Even if we were to go back, Abdikadir, these are people's lives. We don't just say stop, and that's what happened with her. We said stop NHIF, start SHA. Now the transition is part of the big problem. So I think we must also now take time, look at the broad picture, but what are the details that are giving us problems? It doesn't matter what money we have. If we do not work out those details, then we are not getting there. Because we are both right, as Dr. Listenga is saying. The people are saying it is working all right, the people are saying it is not all right, because the systems have not been harmonized, the funding system. And the claim system, when we oppose that bill, is the claim system that we made noise about and the transition part of the bill. So these are problems that we have now to actually work on. I'm not in the opposition that, I'm not of the opinion that just stop everything and reverse. Even if we want reverse, even if you have to go back and review the law, something must work for Kenyans while we are reviewing the law, if that is what it comes to be. And that's why our committee is actually working. Our committee is working to find the facts, not run to the press every time. Find the facts. Even Dr. Lishenga, we have met with him, we'll meet again. That information we are using to work. And we are getting a lot of information from the private sector where things are wrong. Now we are also getting it from the public hospitals directly where things are wrong. We may need to look at the law if necessary, but where we are now, how do we serve the Kenyans with the money that is available? Why don't we look at these system issues? Corruption is everywhere. You will find patients are frauding SHA or NHF before. You will find that caregivers are doing the same. So those are issues that we look at the system. Now we said we have a good system. We are looking at it. If the system is good, how come we are finding so much has been lost in fraud? A good system prevents fraud. It is not for discovering when fraud has happened. So this is the way the committee views it.
Okay, and Dr. Nyikal, one final question for you. Then it's appalling, is it, when an expensive system is unable to detect a fraud of such magnitude as presented by the Cabinet Secretary for Health? And how then should we take this forward? Because ideally it ought to be the first line of defense against such, if then we are to move by the statements and the submissions by the government that moving away from NHIF was because of fraud and other corruption, but still the problem persists.
That is why we are moving around. As I told you, ask Dr. Lisenga there. We have sat with them. Now I'm actually moving around. We are even going to visit St. Mary's that has been stopped. Now, I like to talk to the minister as a health committee and say, Mr. Minister, these are the problems, including that expensive system itself. There's nothing we are not going to question. And if you don't jump, if people go to the press, you don't follow the following day with a press statement. Go down, look at the facts, come with the facts. In the meantime, when you are doing this, try your best so that people who need and deserve treatment get it. Let's not embroil in this fight, a big one, while the Kenyans are losing out. Even the private hospitals, they have to run. If they are not there, there are people who cannot get services. The faith-based, if they are not there, people don't get the service. From me, whether private, public, faith-based, these systems must work. Whichever Kenyan goes to a facility should get a service.
Okay.
Whoever is providing a service should get their due. That is where we are.
Thank you.
Look at systems.
Thank you, Dr. Nyikal, joining us from our Kisumu studios, and he will be now off for an assignment in Homa Bay County. Many thanks, Dr. for your time.
Thanks.
So back in the studio, Dr. Lishenga, Dr. Miskela, and Brown. Of course, I haven't given you the time. We'll respond to. We have an hour to go, so I was just.
I don't know why you didn't give me an opportunity to say.
You will have. Yes, please. Yeah, go ahead.
Please, yeah. It's very unfair. I think when you have me here,
yeah,
and I'm sitting next to Miskela and Dr. Lishenga, you need to also be fair to me.
Yeah. Yes, please. Yeah.
I'm a Kenyan, and I'm a taxpayer as well, and I'm also a health care provider in this country. I'll say it's very unfortunate, and I think Dr. Rida is being very economical with the truth. The truth is SHA has a lot of systemic challenges, and both of them are structural and systemic. And it's very unfortunate that we are having SHA having problems when you're actually rolling out UHC. I believe we are going to discuss about universal health coverage, and SHA is one of the enablers of UHC. You cannot be talking about having a UHC program being successful with the challenges to do with the financing, particularly with the SHA. So we need to have a very honest discussion, Ayub, here. We need to have, let's not sugarcoat things. If things are not working, they're not working. And during the initial stage of SHA, actually, I was privileged to be among the guys who actually gave our inputs. And as Public Health Union, we gave our input strongly. This country, we have a problem when we invite stakeholders to give inputs. We no longer even act on the inputs. Dr. has told you, Miskela has told you, they gave a 25-page inputs on the formation of SHA. We even said, as public health officers, SHA has not provided a mother purchased preventive healthcare services in this country. We're talking about screening, early detection of diseases, cancers, and what have you. SHA is more. Went and didn't even, they didn't bother. And remember, people are actually suffering at the ground. I have members, let me tell you, it's a sad situation in Nakuru and all over, who are admitted and cannot be able to foot their bills because SHA actually is not actually working. And the problem is very simple. I think we're not speaking the problem. Yeah. The problem is about means testing, the proxy means testing procedure. You know, like for example, how many people have registered on SHA? If you ask yourself, and how many, like Kenyans are around 50 million Kenyans, and you get that there are less than even 20 million or 24 million people who are actually registered on SHA. Do you expect 24 million to pay for 50 million? That is a fallacy. It is not true. So, and even those people who are even getting those means testing, the process of means testing, we are not actually, that procedure is not working. Somebody comes in and asks you, for example, how much do you, for example, what is your bank statement, for example, for M-Pesa? How do you own, how many suits do you own, for example? How many pair of shoes do you own? Then he based that to be able to calculate for you what you need to be paying per month. And for example, you know, when during campaigns, and I'm a good student of history, during campaigns, when we were having this government coming in place, there was a talk that we're actually going to reduce, because initially we used to pay 500 on HIF. There was an initial talk that we were actually going to pull 500 to 300 shillings. And Kenyans were very happy. They were saying, now that we're going to having a 300, moving from 500 to 300, it's going to be a very easy thing.
It's now pegged on the percentage.
It's now pegged on percentage, which is, and again, you're told even this percentage you pay for like for a whole year. Let me ask you a question, Ayub. I'm a border guy, for example. I'm a Maboga guy. You come with the means testing, you tell me, for example, I'm supposed to pay 900, for example. Then you calculate for me 900 for 12 months, that's close to 11,000. How can I, for heaven's sake, how can I be able to pay 11,000? And that's why you can be able to see the government itself has killed SHA. I can authoritatively say like that. It is the government that has killed SHA because, number one, it has actually decampaigned SHA. When the president stands up and says, for example, ABCD, actually, it's actually the government that is killing SHA. They have not given supported SHA. They have not come I mean, to the common person, tell them that this is what we need to expect to do from SHA. So I think it's a debate that we need to be honest and delve deeper into it, because health is not free.
Yeah, we will. We'll
health is not
the numbers
free.
as well, and,
yes.
and some of the submissions that you have made. So, gentlemen, let's take a break here on the broadcast. When we come back, we'll extend the conversation for the next 1 hour on the healthcare program in the country and the fraud as announced by the state following the handing over of those files to the Directorate of Criminal Investigations and the National Police Service. But to what effect? After the break here on the broadcast. Stay tuned.